Hello everyone, welcome to our 8th video lecture for our Sociology of Health series. And for this session, we'll talk about the sociology of health organizations and systems. So this will be our topic outline. We'll talk about the social evolution of hospitals from spaces where we conduct healthcare, from the way we understood it across history, and of course different healthcare delivery systems, also looking at it in the context of global perspectives and also local perspectives in the Philippines. And then we'll talk about the different evolutions of health paradigms, meaning what were the popular or the mainstream ways of how health was viewed by health and medical institutions and the larger global perspectives related to that. And then we'll talk about the critical social theory and how it has used health to be able to see power struggles in society, power asymmetries in society, and how healthcare, medicalization sort of reproduces that, vice versa. And then we'll talk specifically about a specific critical social theory on health, which is decoloniality or decolonization, which is also a personal research agenda of mine. And we'll end up with the personal research project that I'm doing in relation to decolonizing healthcare in the Philippines. Just some spoiler alerts for this particular session. We'll be restating some of the principles and concepts that we may have covered in the previous sessions. Treat this sort of as a review or a concluding session wherein we try to put together all of the concepts and then looking at it from a context of how do we transform societies into more just, equitable, rights-based. As I mentioned, the bias of this particular set of sessions that we have is really towards health justice, health equity, and so it is just right that we sort of conclude this through critical social paradigms of health so that we know exactly where health inequalities sort of are centered, where they're mainstream. We have to deconstruct them, what are the forms that they take, how we can sort of expose them, and more importantly, how do we sort of correct them so that we can have not only just health equality, health and social equality or justice in the Philippines, but also elsewhere. So again, a good way of looking at an institution from an sociological institutional perspective is look at it as it evolves across history so that you can also see how societal factors influences the way institutions are understood, are built, are solidified or calcified in society, and so that we can also understand and further appreciate the structures that we have now in terms of the way healthcare is delivered. So, of course, in the beginning, hospitals were thought of as religious and moral institutions, and of course, we can see this in the history of the colonial history of the Philippines, wherein charity and spiritual care was very much entangled in doing healthcare during this time. Hospitals were also manned by, in the Philippines in particular, they're manned by Catholic priests, etc. So they're run by monasteries and religious orders. They focused on charity, so shelter, spiritual care, and managing poverty. Remember, during this time, the medieval period, we're still not yet in the enlightenment of sciences during this time. So the causation of the disease were really rooted on morality and being sinful and having a good relationship with the Lord. And so that was also spiritual healing and spiritual well-being and reconnection and penance was very much a central thing that was being forwarded during this period in this, institutions of health. No? So they're not really primarily curative institutions. They're symptomatic, they're spiritual, etc. And then later on, when sociology was born, through, of course, Auguste Comte, Emil Durkheim, we've seen that hospitals reinforce collective moral values. So for this large institutions sort of are places wherein social values are being socialized, being reproduced, being reified. And of course, this includes charity, solidarity, and Christian duty to look after one's neighbor. And of course, during this time also, disease was sort of functioning in society as sort of a way for us to extend that belief of cosmology, extend of belief of faith as a way of doing correct living, etc. And then also during this time, this was the time to for early social control, wherein poor houses and almshouses blurred boundaries between welfare, punishment, and care, because also at the same time, to mga poor houses where of course some of this symptom treatment, palliative treatment, symptomatic treatment were provided, they were also, expected to do some free labor, which we also see in the Philippines during its colonial time. And so it was also a period of social control, and it was easier to control because back then, faith was used as a rationalizer, of serving. Yon. And then when we got to the birth of the clinical hospitals, when we started to look at that, we have the ideas of clinics, we have the idea of biomedical models of health. So this is where, of course, we move through with science, because during this time we also discovered germ theory, we also discovered pasteurization, and so hospitals were also places wherein these were celebrated. These were put it for in order to heal and treat. So ito medyo curative na yung kanilang tingin. So hospitals become a sites of systematic observation, diagnosis. It also housed laboratories of pathology wherein, certain body parts or fluids from bodies were being examined for certain diseases so that cures can be detected or, advanced. And they also became centers of classification. As you know, very stratified the medical practice. So you have cardiology, you have nuclear medicine, you have orthopedics, you have pediatrics. And so we can really see, in the modern society, it's becoming more specialized, and we see that also in the medical field. But of course, during this time, it's really more of pathogenesis, really more of infectious disease during this time before we really started thinking about communicable disease. And of course, during this time, in Foucault's work, Foucault also did some historical work in terms of the medical institutions, and it was Foucault who coined the term medical gaze, or in some books it's called clinical gaze. So in short, medicine as an institution, which is also very much a bastion of science, also was very much instrumental for social control. So according to the book of Foucault on the birth of clinic, hospitals recognized knowledge around the clinical gaze. And so during this time, hospitals were important institutions used by the elites, by those in power, to get people in line, to control colonized bodies, right? And so patients became cases, and this is, of course, prior to this, where there were no ethics that were being done. And so studying patients, humans, were, easy to get by the doctors during this time. And so the body became an object of surveillance and classification. This was also the birth of, pathologizing homosexuality, pathologizing same-sex desire, pathologizing effeminacy. So, and so because of that power that was vested by society on the medical institution was very much had a great hand in terms of power asymmetries that are really injected into the normalized discourses that we still hold true today. And so, again, like I said, entangled na yung medical knowledge with institutional power. So now, hospitals are not only just places where care happened, where healing happened, but also they become knowledge-producing institutions. And during this time, industrial period, it was also bridging towards knowledge economies. And so knowledge was also alongside innovations, alongside industrialization. It was a very important prerequisite for development during this time. So when your institution produces a lot of knowledge, that knowledge gets translated into innovation, that innovation can get marketed, then you also become a powerful institution. And in the States, eventually, in the late 19th and early 20th century, we've seen the rise of medical authority, where hospitals became training centers for future doctors, surgical innovation sites, and again, in the early 1900s, there's really not it was only in the 1950s that we started having research ethics, medical ethics, and there's really a lot that we learned about anatomy prior to that period, because there were in the hospitals it was also it's a center of research, but those research some of them were unethical. Like, for example, black bodies, enslaved people were being used. They were intentionally intentionally injected with diseases, and then they were being tested, and then the clinical features of a particular disease or a particular pathogen is being observed on them. And so, because of these horrific cases along the latter half of the 20th century, we now have strict human ethics research, and then we're improving that as we go to the time. But and then of course there's the professional monopolies that we still have now, and we've discussed this in the prior session. And then we also discussed about Elliot Fridson in the last session about how doctors became very autonomous, how physicians became a very powerful industry, how they get to choose what to study, that who gets to be the next doctor in the future. Although of course we do know now that because of commercialization and the resistance to and decreasing public trust on medicine and anti-science sentiments, we are now seeking a decrease of trust on physicians. But during this time, the physicians were as powerful as the politicians during the time. And also, politicians were using physicians to be able to segregate bodies, to be able to say that these things are bad. We're going to classify you as bad. So, things like that. And then, of course, during this time, the hospital was also a very good site where we are able to move from traditional thinking to rational thinking and the building of formal organizations with bureaucracy. And one of the very specialized and very diverse but stratified organizations during the time and until this years, although ngayon mas nagiging corporate-like na ang hospitals. But during earlier, hospitals had its own very specific way of organizing people in a formal organization. So you have a separate department for physicians, you have a separate department for nurses, you have a separate department for ancillary, you have a separate department for nutrition and dietetics, you have a separate department, but they have roles to fill in that particular hospital. And then of course there's a lot of writing that is being done to communicate within disciplines and outside disciplines. Writing was very important. Doctors made their orders, nurses made their notes. That's how they converse with each other. It's important to produce these things in that bureaucracy because we have to maintain rationality in the work that we do. Because again, in the context of bureaucracy and scientific management, eventually in the theorization of Taylor or Taylorism, very important that we understand that humans have cognitive failings, and so we really need to make sure that we have to be impersonal and we have to put things in policies and programs and procedures so that we make sure that our work is close to flawless. No? And so the hospital is where we see some of bureaucracy, good cases of bureaucracy during this time. There's hierarchical authority, right? So, for example, among doctors, no, you have the top of the food chain, the head of the department, and then you have your consultants, and then you have your residents, and then you have your interns, and this is the top of the food chain, no? Probably you've watched. I do not watch a much Grey's Anatomy, but I've watched enough reels on Instagram to be able to get the gist. But you can see sort of how people sort of climb that ladder and what type of insights you get at the top, and what power you sort of amass when you get into the top, no? And also that's the same for nurses, no? First nurses, you have staff nurses, and then in every ward there's a charge nurse, who's the head in that particular shift. You have a head nurse for a particular ward, which is across the shifts. That head nurse is the head, no? And then you have a division chair and a training officer, and then of course they have very specialized roles for the hospital. Ayan, division of labor and rational legal governance. As I mentioned, there's a lot of paperwork that we do. That's one of the things that really actually sort of take a lot of our time, no, as health professionals. But again, it feeds into that bureaucracy. So now, that is the nature of the hospital. It has become a bureaucracy. It has become a formal organization. An example of Weberian rationalization. And then, of course, I will not be getting into this, no, but of course, we've seen Talcott Parsons, the sequel, etc. But I guess what will zero in terms of Talcott Parsons' work is what Talcott Parsons thought about hospitals. So hospitals, according to Talcott Parsons, is a bridging institution. No? It's a social regulation institution, so that those who are sick, no, would have a way for them to become functional again for society. So that's sort of the function of hospitals and institutions. Because, Talcott Parsons, functionalism, etc. Irving Goffman also made use of psychiatric hospitals, in viewing society as well. So, for example, it is Irving Goffman, in their work on total institutions, one of the examples that they provided was the psychiatric hospital, wherein psychiatric hospital, because of the lack of or some issues with cognition and affect management and sensory issues of people who were living with schizophrenia or other mental health disorders that are debilitating, they have to be put in a very structured environment. So, may oras ng pagligo, may oras ng pagkain, may oras ng gamutan, may oras ng pahinga, etc. And so, it's to that point that there's not much agency for the people to really decide what they do with their lives, with the space that they're provided, and with the time that they have, because these are provided. So that's called total institutions. You don't have much autonomy. And then, of course, we applied that idea of total institutions, that was derived from psychiatric hospitals to other forms of total institutions like jails, prisons, and also total institutions are convents, for example. For example, priests and nuns, particularly those in training, have very structured ways of living, and also they are under the vow of vigilance. So there's a lot of autonomy that they sort of have to give up, for them to be able to have or gain that identity, or gain that legitimization of to become a consecrated individual. But of course, Irving Goffman initially used the psychiatric hospital as a case for total institutions. And so, again, these are spaces where identity is stripped and reconstructed, rehabilitated if needed, particularly for prisons. It also revealed power asymmetries and ritual degradation. Prior to conversations around dignified caring for people living with schizophrenia, for example, I would hear about horror stories about when schizophrenic people are being bathed, nandun lang sila sa gitna at hino-host lang sila. So that's very degrading, and this is an example of a total institution. And so, as we know, Irving Goffman works within the symbolic interactional micro-sociology moment or paradigm. So this is one of the ways that Irving Goffman sort of looked into medicine and also used medical institutions in understanding other similar institutions in our society. And then we did talk about medicalization and the expansion of institutional power outside the hospital. So we now, and of course, we discussed in earlier sessions about the idea of medicalizations, wherein normal life courses have been pathologized, have been put under the care of medicine. Like for example, childbirth, which used to be a natural thing that is happening, now has to be done in hospital, now has to be done in lying in hospitals. Menopause, for example, or mental health or behavioral disorders or aging is now something that needs to be looked in the hospital. If wearing my hat as a nurse, I do understand why that is, but we also have, from wearing my hat as a sociologist, I also have to critique about that when these places exist, we also have to look at like what power imbalances or asymmetries exist in that particular space, And of course, there's also that idea from Foucault called biopower, wherein institutions regulate populations by managing life, like controlling birth, monitoring mortality, controlling risk. For example, there are for aging populations like in Japan, they are really doing making policies so that women and men would want to date, and women become fertile, to become pregnant, because again, dumidecrease na yung kanilang replacement population for productive people, because hindi mababa na yung fertility rate nila, and so that becomes demography becomes now a interventional site, and so that is the way sort of the institutions and governments and the state sort of bleeds into our life, bleeds into our bodies, and tells us, Naya, you have to procreate because you need to, And also the same thing for those who wants to control their population. You need to use family planning because we have to control the population. So that's called biopower. So the extent to which the state is able to, to mandate things, to make you stop doing something healthy that you would otherwise do given enough agency, So, and then of course, in conflict perspective, which is still very much useful again to now, healthcare is very much embedded with capitalism, and we don't have to look very far. In the Philippines, it's not that crazy, but when you look at in the States about how the extent to which price gouging for basic paraphernalia like insulin that's really just so crazy. So if you're poor, you're dead. So that's really sad. In the Philippines, yes, we do see better healthcare for those in higher tiered hospitals, and of course we see poorer care, not because it's the fault of the institution, it's just that they're underfunded, so you don't expect a lot of specialized care there. So yeah. And then we do know already about how inequality, increases stratified care. We don't have to go back to this anymore. But when you go back to social epidemiology discussions, we know how gender, how social equality, ethnicity, race, religious background influences our outcomes, And then, of course, going back to Link and Phelan's idea of fundamental cost theory about how income level, socioeconomic status is actually a barrier to getting good hospital interventions and therefore could lead to poor health outcomes. And then eventually in the late 20th century, in the early 21st century, somehow neoliberalism sort of eased itself into all institutions. So when you look at institutions now, whether that's a school, whether that's a hospital, whether that's a government institution, a corporate institution, a finance institution, everybody has a president, a vice president, a COO, a CTO, a CEO. So because that idea of structuring, making organizations efficient, having that same logical parlance of corporatism and managerialism is now found in all types of. So dati, no, before we call the top honcho in nursing departments as chief nurses. But now, big hospitals call them vice president for nursing. So, again, so managerialism sort of makes institutions more alike. You know? You may have already learned this in your social organizations, sociology of organization institutions, how organizations, you know, tend to be affected by the other organizations around them. They become more alike, you know, and so that is what is happening now, which has its good side, but also you do know that it's serving corporatists' interest, no, because they're gunning for the same accreditation, so they have to have the same language in their organizational structure, etc. No, and so now what happens is that we treat factory outputs, like for example, we treat yung time and motion study for factory outputs as the same time and motion output as providing bedside care, which is we have already productized, no? We have naging product-centered yung care. And so now we're counting care, counting how much we're spending for care, instead of really counting, did patients really become better? Did they feel that they were human in the care? Or were there just numbers for strategic planning? Same as also probably what you notice in schools, no? So the closer they are in terms of this neoliberal corporatist managerial language, the more the outcomes or the outlook of that organization sounds more like a product, even if it's a service, right? So yeah, so there's audit culture, no? So we're now counting how many nosocomial infections. When you say nosocomial infections, the infections that you get while you are in the hospital. So hospital-acquired infections, how many ang HAMA? HAMA means Home Against Medical Advice. So gusto natin mababa yung Home Against Medical Advice. Ilan ang nagagastos? No, how long are the operations? We want to shorten the operations because we want to have more people being operated on every single day, right? So, how many, and then in terms of how many gloves have been used, things like that are being counted, no? And so we are also obsessed with performance matrix to the point that, for example, in nursing, we value caring. How do you measure caring? How do you measure curative behavior? And so we try to quantify things. So one of the things that I am sort of actively doing my research on is on that, right? So like how do you, diba? So is it patient satisfaction? But is patient satisfaction really able to measure or really able to qualify the care, the mindfulness of the care that was received by the patient, the quality of the communication that was provided? But because we are living in a managerial, when the accreditation of PhilHealth, the accreditation of the Joint Institution for Hospital Accreditation, or Joint Council for Accreditation of Hospital Organizations, or JCAHO, diba? They want you to be using metrics. They want you to be crunching numbers. So how do you put numbers on those things? There are things that you can put numbers on, like money. Of course, those are things that you can count. But for example, good service, good care, how do you count that? But your accreditors will expect you to count something. So you have to quantify those things somehow. And I'm a statistics teacher and I'm still really off with that. No, I'm really not very sold into that, but that has to happen because this is how our system is right now. Very corporatist, very hospital. So again, financial efficiency models, and of course, governmentality, meaning individual responsibilization, the extent to which you are governing your own lifestyle, governing your own, instead of the responsibility with the institution. Or no, so we have data governance, performance monitoring as governmentality, and risk management being performed by the data that we have. So there's increasing pagpasok at the individual level ng governance. So hospitals now become sites of measurement, accountability regimes, and financial calculation. And then in the 21st century, where we are now, we have an increasing technological transformation. So now we have electronic health records, not only for the top hospitals, for rural hospitals. Diyos ko Lord, mahirap yan. But we are being taught that in nursing school, nursing informatics, we call it. We even have a laboratory for that. But when we go to say, a poor hospital, wala naman electronic records doon, magsusulat pa rin naman kami. But why are we being trained on that? We're being trained on that because eventually when we get exported to the States or we get exported to a developed country, they have EHRs. And we have to know that already. Now there's increasing AI triage. I've seen the crazy things that are being done by my colleagues, in their specific nursing institutions that are very rich in other countries. Like they are really doing triaging and AI to be able to do care to their patients. I have qualms with that, but it's amazing how they even think about how AI can help in triage. When I say triaging, it means classifying the patients that are in front of you so that you can prioritize who gets to be cared first, especially when there is a minimal amount of people to provide the care. So, syempre, the more higher severity, uunahin mo sila sa care. So, that's triage. Triage is very important, particularly in disaster and calamity situations when you're only 5 responders and there's 100 people who are stranded in a calamity. You have to do quick triage. In a 30-second, you already have to have a priority of who you should take care first because they need life-saving something already, put them in the ambulance because if you don't, they would die. But for example, nagalusan lang, tsaka na muna sila. So that's what triaging is, classification of patients in terms of priority of care received. We have also predictive analysis, and this is getting scary. Like for example, we are now able to crunch numbers of this is your, again, and this is also something that we see that sociology sort of feeds into that. Like for example, when we are seeing that these are the social variables that basically predicts you to have cancer, then you can get tagged of being a cancer risk. We've seen this, for example, in Angelina Jolie, for example, she was found to have a particular gene that's not yet cancerous but could be cancerous, so she had a mastectomy. And there are a lot of bioethical questions about that. Is that bioethically okay? And so that's the body autonomy people and also the people the sanctity of the body people. So that's a different question altogether. And then, of course, the increasing of telemedicine. This one I'm okay with, telemedicine, particularly in a very highly connected. There's so many things that telemedicine has helped. Like, for example, if there is let's say there's no dermatology specialist in a particular rural barangay, and somebody has to look at their lesion so that you want to see if they're cancerous, and the dermatologist who knows how to do that is in NCR, the person can take a picture of their lesion, send it via email or send it via a telemedicine application, and then the doctor can make a diagnosis based on the observation. So telemedicine for me is very okay, especially for purposes of clinical treatment, especially for purposes of when a patient can't really be mobile. Telemedicine is very okay for me. And then, of course, we have Ulrich Beck and the idea of risk society, wherein because we have a lot of algorithmic power, we have AI power, predictive affordances. Now, the society is able to see a lot of risks, and we are already managing risks even if the detriments are still yet to come. And so, pinaproblematize ni Beck yun, Is it really right for us to intervene for a risk instead of an actual outcome of a disease. Now, risk, when institutions become obsessed with risk, it also means that they're obsessed with controlling bodies. Because if I'm able to decide with risk instead of, actual disease, then that might be a problem. Because that might, say more power, right? Etc. And then, of course, surveillance medicine, governmentality, and biopower, So, your health behaviors are being tracked because of your social media. And so, your data behaviors, your click trails are being sold to advertisers so that they can push healthy products on you. Yan, these are our problems now. So, ano yung mga imagined futures natin ng hospital? So, we see, well, of course, the most nice one is a network hospitals wherein we don't see hospitals as like a hospital na building, but we are looking at a networked health system. Like, what we were imagining in session 3 on Philippine healthcare delivery system wherein we would want like people not going directly to the hospital when it's not yet really that dire and going to a barangay health center first or going to a local clinic first so that the expenditure is not that high. And then of course we have a post-professional hospital, and oh my gosh, I've seen this play out. Last December I went to Hong Kong. I was watching some presentations of Singaporean colleagues of nursing, and they really have AI tutors now teaching their students. Parang the AI tutors are teaching the students how to act together, and so like, oh my gosh. So I don't know how dire that is, but according to them, it's effective. It's as effective as person-to-person contact in teaching. But I can just imagine about how this technology can further impact that. We are also seeing increasing corporatization of health, and we've seen that already, monopolizing health. At least sa Philippines, hindi ganun kalala, but when you look at the United States, wala silang universal healthcare, and then, it's for-profit and everything, and then merong just a few people holding these decisions, and so they can hoard more money, they can monopolize. So sad. But also what we want to do is to be able to have a community embedded public hospital, meaning we want hospitals that are directly accessible to the community, but of course we can only dream at the moment. Hopefully with good governance that becomes a reality. So, across history, what were the sociological tensions that we've seen? So, we've seen care, hospitals and healthcare institutions as a site of care and also as a site of control. We've also seen about what the role of the professions and the agency that they have, the power that they have, but also at the same time, how bureaucracies, formal organizations sort of, support that or at least intensify that or usurps professional autonomy, which again, we've seen now in mega corporate health systems na usurp yung doctors, right? So for example, the doctors would say na, I am going to say na, I'm going to endorse this particular issue as an insurable disease or an insurable case, but if the corporatists say, no, I don't think that's an insurable disease. So it usurps the professional autonomy, So may ganun na rin ngayon. And then of course, equity versus marketization, which is, again, Yon. And then we have human judgment versus algorithmic governance. We're seeing that more and more. And then hospital as a place and hospital as an ecosystem or a network. So when we talk about medical institutions, usually the first thing that you think about is the hospital. But more and more, and probably when you go back to session 3, you know that when you talk about medical or healthcare delivery system, it really is in the context of different departments working together, different organizations working together to provide the best healthcare under a larger regulatory system. And then just really going back about the different evolutions of the hospitals, I'd like to, of course, zero in on the colonial history that we have, no, about how a lot of our pre-colonial medical knowledge and health care knowledge and epistemologies have been erased or sidelined when they came and have been pathologized. Actually, there is a writing from a medical historian from UP that said that one of the wins, according to the colonial public health system in the Philippines during the American occupation, was that it is the public sanitation and hygiene. And actually, they were saying that it is the traditional experiences of the traditional healing practices of the Filipinos that actually caused them to be sick in the first place. And so what happened was we demonized and pathologized local healing, no? So of course, we have post-independence, we have the Ministry of Health, but then eventually it became decentralized in 1991, and we've seen the horrors of that, what happened when your institutional capacity is not the same. And then of course, we now have the health insurance, the PhilHealth in 1994, and then eventually it became universal healthcare in around prior to 2020, but still we haven't realized fully what universal healthcare is. But even with those, we still have persistent inequalities that is based on geographical issues and class issues. And then, of course, major issue, we have your workforce brain drain, our hospital, our nurses, our occupational therapists, respiratory therapists, radiology technicians. They're flying to Middle East, they're flying to the States, to the UK. I just don't know now how the care chain is affected by the war that we're experiencing now. But yeah. Now, in the textbooks that I provided you, there was a comparison of developed nations and the United States. I think let's localize it to our country. So developed nations, particularly the more democratic developed nations, particularly we're looking at Finland, Canada, those that have universal healthcare. So ano yung difference nila from us? So one, ang structure ng Philippines ay decentralized, and we've seen the horrors of decentralization. It was ideally okay sana if the capacity was the same, pero if the finances, the capacities, and the priorities are not the same, then we would see inequalities. But in countries that are developed and having universal healthcare, it is actually centralized. So it means that there is a single payer. So when there's a single payer, if it's the government is the only one paying for medical services, then they can monopolize, they can justify, or they can argue and regulate the prices, right? And then of course, one of the problems in the Philippines, I think also one of the reasons why we have to decentralize is because we have a very, very peculiar geography. We are an archipelago, so it's really harder to really have a unified health system at the moment, no? But for those who are, just one landmass, just a few islands here and there, it's easier for them to really have a particular network system. And of course, in terms of workforce, tayo ang nagdadala ng workforce kaya mas okay sa developed nations, no? So the UHC, the universal health, the NHS, the National Health System of UK benefits a lot from those who are leaving from the Philippines, no, to work for them. So, yun na nga yung problema natin sa global care chain na ito, na naiiwan yung mga nagtitrain, na yung mga training grounds, yung pinanggagalingan ng mga nurses, sila pa yung nagkakaroon ng health inequalities or health resource scarcity. In financing, may mixed models. So, merong magpipay ng particular portion si PhilHealth, and then magpipay din ikaw out of pocket, no? But in the developed nations, particularly those who are really doing universal healthcare, no, it is the government that pays. And so because you're a single purchaser, then you can be the one to say that this is the extent to which I can pay, and there's no one else is going to pay. It's just me, just the government, so I can regulate the payment, no? And then so those are our differences, no, from developed nations. Now, there are different health paradigms that went on through. So, and some of them we have discussed already, meaning paradigms, how what health was looked at by physicians and healthcare practitioners and how they were approached in terms of addressing these issues. Of course, the earliest one is the biomedical model, seeing the body as a mechanism with nuts and bolts, and that parts, if you want to heal someone, you have to treat, which parts are not working well. But eventually we move from individual care to public health, which we want to be able to prevent disease through vaccination, through sanitation, through healthy behavior and health education. And then we now have community health and primary health care. Primary health care is putting a lot of investment on disease prevention, illness prevention, and health promotion. And also putting health promoting people in every community, so to ensure that they have increased access to care. Community healthcare is also capacitating people to be able to address their own needs. For example, in our case, when we're doing community organizing as nurses, one of the things that we have to do is that we have to make sure that every purok or every iskinita in a barangay, there's someone who knows how to take blood pressure. So that when somebody is experiencing any symptom of high blood pressure, that person can go to the neighbor who knows how to do BP, so that they can assess the BP. So if the BP is too high, they can decide to bring the person to the hospital. So that's an example of a community health intervention, giving capacity to community people so that at least sila yung front line of care that can be done. So yun are some of the things that you can do. Or for example, mothers, you put them together, you teach them about reproductive health, and then they sort of, spread the word around. So yun example. And then we have the social determinants of health. We've discussed this already. We have the biopsychosocial model by Engel, noting that the biomedical model of looking just at the biophysiological things in the person to heal them is not enough. You have to look at their biological state, their psychological state, and also their social relationship and the institutions where they belong and the social environments that they have. And then, of course, we had in the 2000s the commercial determinants of health, and we've discussed that, how market and elite forces influences, health disparities. So it is a more critical version of social. And so, just I want to note here, because maybe we haven't discussed this in full detail, we have now what we call One Health. So One Health is, when we talk about health, we always talk about human health. But the argument of One Health is that you have to think about three things. You have to think about human health, you have to think about animal health, because there's a lot of the problems that we have are really zoonotic diseases. When you say zoonotic, nanggaling sa animals. Example ng zoonotic disease is leptospirosis. Nanggaling yung leptospirosis mula sa urine ng daga. So that's an example of a zoonotic disease. But also there are diseases that really, like for example, bird flu coming into humans, foot and mouth disease from cows coming to humans. So with the transfer to humans, yun ang ayaw natin. So dapat we also take care of the health of animals so that there is yung barrier, yung zoonotic barrier is not crossed. So in One Health, it's not really just the physicians, but the veterinarians, the public health veterinarians, the public health zoologists must also be there. And of course, the third one is in the environment, because again, we talk about ecosystems. Ang pagkakaiba lang niya with eco-health is that eco-health is more focused on the environmental part. But I would argue na, so dito ay global health, So meron, nagkaroon, ang una niyang pangalan was international health. Ibig sabihin, we're looking at diseases or health conditions that sort of are found across borders. And then ang argument natin is hindi lang siya international, it's actually global health. Because for example, climate change is a global issue. Then eventually, ang problema sa global health, ang argument niya is we focused on human and social institutions, but we don't think about the planetary ecosystem, particularly the land, the water, the soil, the animals. And that was the birth of what we now using the planetary health model, wherein we look at human systems, we look at social economic systems, and we also look at earth systems. Earth systems being ecology, biodiversity, water, pollution, climate change, etc. Because we believe that we all live in the same planet, and the planet of the health is also our health at the same time. So many of the health are going this way. So planetary health sort of emerged alongside the Sustainable Development Goals, and this is one of the more sikat na planet na health paradigms that are being looked at, and many of the health disciplines are going towards this side, including nursing, including me. But also there is a conversation around, sino ba dapat? Ano ba ang mas umbrella? Planetary health ba or One Health? Or One Health ba or planetary health? So there's a conversation about that. I think it's because there are really disciplines who are more privy in doing One Health. Kasi nga, for example, veterinarians, they're more privy in kasi meron talagang focus on animal health. No? So things like that. And then very, very quickly, how did critical social theory look at the evolution of critical social theory? When I say critical social theory, it's how, we did social thought and social theory and sociological theory against power, about looking at social transformation. So that's critical social theory, and that's basically one of the things that I'm interested in as a researcher. No, so I'll just put you through the memory lane, no? So for Marxist political economy of health, so we talk about political economy, marketization, capitalism, and how that this causes health inequities. Then eventually we had social medicine, which says now we don't have to look at medicine just as biomedical phenomenon, but also social phenomenon. So this challenged the medical institutions to look beyond biophysiologicals. And then of course we have the Frankfurt School about hegemony. No, this is where we start asking about governance, no, participatory, doing participatory work, no, and how medicine sort of contributes to political and elitist dominance, no. And then of course we have medicalization. I will not repeat that again, no. And then we have postmodern social constructionism, no, our conversations around medicine being one of the reasons why we have pathologization of identities, no. So for example, dati we thought of homosexuality as a disease because according to DSM-3 siya ay disease, and then it became gender identity crisis, and then it became gender dysphoria. So again, postmodernity and post-structuralism argues that the structures that are made of by the language sort of has broke that, no, has to be broken down, has to be interrogated in terms of the power that they are able to deploy and the inequalities that they are able to normalize, no. So that is for and then that health is a social construction as well, no. And then of course we talked about Foucauldian biopolitics, about surveillance, governmentality, responsibilization, and biopower, the clinical gaze earlier. And then of course feminists also look at health, at so dito na tayo nagkaroon ng reproductive awareness, reproductive autonomy, body autonomy, conversations about abortion. So this is within that area of conversation. And then of course, along those lines is intersectionality, arguing that different axes of power sort of multiply and act on each other so that it intensifies and changes the shape of the dominance and inequalities that we're experiencing. And then of course we have queer theory about how our sexual identities and desires sort of are helping in categorizing people, pathologizing people. And one of the key diseases that queer theory sort of interrogates is HIV, how it was used to be called the gay disease, but eventually di naman talaga siya gay disease, no. It's really just a disease that is sexually transmitted. It just so happens that during the time, there's a lot of gay people or a lot of people who have sex with other men who gets this, no? So that's an example of how queer theory in health. And then of course we have the structural inequality and the social determinants, no? And then we also have neoliberalism and health governance. So in short, yung managerialism na sinasabi natin kanina, audit culture, corporatization of the health institution, ito yon. And then we have post-colonial and decolonial health. Ibig sabihin, our colonial histories are still creeping up on the way we do our health today. And I'll discuss that in a little while later. And then, we have eco-social and embodiment theory. So, ito yung sinasabi natin that the social determinants of health literally gets into your body, becomes social stress, becomes illnesses, no? Ayan. And then, of course, we had commercial determinants of health. We had pharmaceuticalization. So, the pharmaceuticalization of society is that when there's a problem, there's a meds for that. Diba? Parang, naalala ko nun dati, lutein para sa mata. You have a supplement for every part of your lungs, for every part of your body, even if there's no therapeutic claims approved. Right? So, that's an example of pharmaceutical. Or, for example, this is also a critique, no, sa pharmaceuticalization of psychiatry, for instance, na parang before we address the structural issues that made you depressed in the first place, so ito muna, inom ko muna ng antidepressant. My argument, though, is that they can happen at the same time. Let's discuss the structural determinants that made us social stress at the first place, but at the same time, we have to make that person live a good life. So while we are fixing structural issues, and we have to improve resilience as well. And if worse comes to worse and it's really dire that the person needs medical attention or pharmaceutical interventions of psychopharmacology for us to be able to address the symptoms so that they can live better, that would be great. And then, of course, the argument of posthumanism and new materialism, meaning when we talk about health, bakit health lang ng tao, but hindi health ng animals, but hindi health ng river, hindi health ng mga puno, and also conversations around, wala nga bang agency ang mga computer who are deciding for the care that we receive, for the electronic health records? Don't they also determine our destiny? So these are the conversations of post-humanists, no? That entanglement of human and non-human systems. And of course, planetary health, we discussed that earlier. And then of course, digitalization and technosolutionism, no, na parang, there's an app for that, no? So parang, for example, I think one of the issues in technosolutionism is like, this is always the priority of the government in terms of innovation. If you can create an app for that, go. Which eventually, nobody really gets, the marketing of the app is not so good, hindi na-uptake yung app, no, yun na laging problema. No? Next, we have the datafication of health. So, we discussed that earlier. And the political ecology of health, the planetary health. Now, a few final slides. No? We'll talk about decolonization or decoloniality. Pagka sinabi natin coloniality, it means that even after the formal emancipation of the colonial nations, meron pa rin colonial matrix of power that persists in the post-colonial states. So, ibig sabihin, in the Philippines, for example, we have been a colony of Japan, a colony of America. I'll focus more on America because they're more pervasive, no? Their culture, no, still has a lot of dominance in the way we do our lives, no? And there's a lot of what we lost during colonialism that we were not able to revitalize as of yet. And even if we have to revitalize them, they still have to be looked at from the gaze of the West, from the gaze of science. And for example, when you talk about folk healing, when you talk about herbolario, when you talk about faith healing, no, mga ganon, folk healing, traditional medicine, when you look at it from a biomedical lens, it loses the spirit, no? It loses the generations of historical knowledge that really it's based on land. It's a land-based treatment. It's a land-based intervention that will never fit into the very biomedical positivist way of looking at health from a medical perspective. And so, what happened is that while wala na yung mga Amerikano dito, we still have their public health structures. Andito pa rin sila. The books that we're reading for physicians, for nurses, are still made by foreign authors. The theories that we are learning, still from the authors. And that's the same thing you can say for sociology. We still talk about Weber. We talk about Auguste Comte. We talk about Marx, as if there's no thinker in the Philippines who have done something similar, or at least more culturally humble. No? And that's the same for medicine. And that's basically one of the things that I am passionately working on. And so the work is to decolonize, meaning to deconstruct how these colonial structures of thought, of culture, still permeates the way we do our health. No? So probably you've heard me in some of our classes, talking about we shouldn't talk about traditional healing that way because, or we don't have to talk about herbolaris that way or suog that way. While, of course, from a biomedical perspective, when you look at them, they don't look so effective. They look very occultist. No? But again, that's your lens. That's very colonial. That's looking at it. No? But for people who are actually benefiting from it, why are we not mainstreaming it for them? So, yon. So there are different asymmetries here. The first one is global north and global south. And we probably have heard of Wallerstein, for example, no? And the peripheries and the centers. And so in terms of the knowledge, health knowledge, medical knowledge, many of the medical knowledge really come from the global north, tested on global north people, and then we just apply them on global south people, which may have different cultural ways of doing things. No? Next is colonial legacies and neo-colonialism. I explained that earlier. No? And then epistemic injustice, no? The marginalization of indigenous and local knowledge system in Western hegemony in the formal education of physicians and nurses and other allied health practitioners. And I've done some research on that already. I think I've done enough. I've done more research on that, no, already, and I'll show you a little bit later, no. And what are some key manifestations of coloniality? One is a lot of our low and middle income countries are, still suffering a lot of health inequalities. For example, for Global North, and for sino ang nauna sa vaccines, mga taga Global North. Why? Because all of the knowledge is concentrated there. So sila yung nauna sa COVID-19 vaccines, and then naghihintay tayo kung meron sa ating mapupunta later. Because we don't have our own vaccination, production centers. And then another issue is the parachute research. Pupunta dito yung mga taga CDC sa states, yung mga taga USAID sa states, 'di ba? Kukuha sila ng data mula sa atin, or magte-test sila ng mga bago nilang meds sa mga Pilipino, tapos ibebenta nila yung mga nagawa nilang mga meds doon sa mga nakakabili. Tapos yung presyo ng mga meds na magagawa nila hindi ma-afford ng mga tao sa Pilipinas. Pero you tested the meds in the Philippines. Or, for example, you come to the Philippines, you get, or you go to the mountains, you get a very exotic plant, and then that plant, you are able to inoculate a specific chemical from that plant. That chemical becomes a medication. The question is, will the community taking care of those plants have a profit pag nabenta ka mo ng medications mo? So that's another example of coloniality, no? Also capitalism as well, no? And then the structural dependency, no? Particularly because of the loans, particularly because of the diplomatic agreements that we've had, and we've seen this play out in the current situation that we're having now in the war, etc. Diba? But at the same time, isa dun sa mga pinapangako din natin kasi sa mga high income ay yung ating mga nurse, yung ating mga doctors, yung ating mga scientists. So that's a part of that's a part of the dependence that we've had, no. And again, also at the same time, no, yung fact na yung basura nila sa atin papadala tayo tayo kaya ang pinakamalaki ang plastic waste because we import a lot of wastes from other countries because as part of the diplomatic thingies that we're doing, diba? So conversations like that needs to be had, no. And of course, more importantly, climate injustice, no. Ang baba ng ating carbon footprint pero tayo ang inaatake ng mga super typhoons, hindi naman yung mga highest carbon footprint countries. So yan. Yeah, no. So again, we have the knowledge hierarchy with the Western biomedical knowledge, no, sidelining our indigenous knowledges, and there's academic gatekeeping, which I know so well, no, which is like, for example, bakit for them pag America or pag UK yung author, it's easier for them to say yes to a certain publication, pero pag Philippines medyo mas matindi yung kanilang reviewing process, particularly at the editorial level. So that's my beef. That's my beef. No, I have a lot of beef with that. No, as a person doing academic publications, I have to push back against some reviewers who kind of raise their eyebrows. Well, what would a Filipino researcher or Filipino epistemologic or Filipino philosophy really benefit a global stage? And that's what I'm fighting for. Na parang, so, you have to move aside a little bit, no? And of course, you have the brain drain, no? You have your care, you have the care extractivism, caregivers, nurses being sent to high-income countries. So sad. So, what do we want? One, we have to have structural overhaul. So, that's one way of decolonizing. So, sana, we have to decrease the gatekeeping for medical, for medical knowledge, etc. Agency and self-determination. Sana, tayo sa Pilipinas, for example, we have our own journals that are also celebrated like they're celebrated in the West. But most of the time kasi when we wanna be able to do self-determination, it's really good to do it with solidarity. So usually we have to look at other global South nations like Africa, those in Africa and in Latin America. We have to have epistemic reformation, and this is what I am personally sort of engaging in very strongly as a nurse scholar. No, I'm really saying that many of the theories that we've been taught are Western, and we're trying to really just interrogate that. Is this something really that you can apply universally and blindly on all cultures? And so what I argue is that maybe we also have to have our chance at producing our knowledge, and maybe we put it in the center of the conversation, and maybe other people will also be able to use it, not just you feeding your Western theories on us, no. Educational reform. So, oh my gosh, I have a whole publication on critically, so sa mga students ko na critical discourse analysis. No, I did the critical discourse analysis on the curriculum of nursing in the Philippines. And there are many things that I've seen that needs reform. One, over-reliance on foreign books. No? Which the books that I also used when I was still a nurse. So, and I can imagine it's the same for medical technologists, for physician education. So those things like that. Addition of subjects that are not really grounded on Philippine reality, like again, nursing informatics. While of course we want to have electronic health records, but it doesn't really have to have 5 units, 2 units of laboratory, no? And also, did you capacitate the nurses to really have like an education? Anyway, I'm saying a lot about that. And this is what I want, no? So they must cede their seats, and this is something that global north scientists are really hard. Hindi sila makabitaw sa central knowledge, right? So, and I've noticed this in a lot of writings that I write, no, they're resisting some of the interrogations that we are making, no, particularly decolonial scholars aside from myself. No, talaga may kita mo sila, they are trying to repair the work that they do so that we can include you. No, we're creating things. Just put us in the center. You don't have, because you had your time in the sun. You have to seed your powers. You have to make space. You have to, step back a bit. Yeah. And this is equally true for sociology. Although sociology, I would argue, is a more intentional in terms of decolonizing as opposed to medical. Kami kasi talagang medyo nanlalaban pa kami. But I would argue social sciences are more intentional na about, let's seed our powers. When we are from the global north, we have to seed our powers so that we amplify more voices from the global south. No? Ayan. So there are temporal triggers for decolonization discourse. So we have Black Lives Matter, no, and also decolonial scholars, no, that are going through different. So there's a lot to think in cultural studies, and then sa sociology, of course, sila Alatas, no, we're using that, and I'm using those tools for me naman to use decolonial sociology on nursing, no, so that and this is the problem, because in the conversations of decoloniality, 75% pa rin ay nasa global north. Although I do understand that another form of decoloniality is settler colonialism. So for example, First Nation countries in Canada and Aboriginal populations in Australia, sila yung malaki. And they're still in the global north. Pero when you zoom in Canada, for example, may mga colonial histories din doon. At doon mga dispossession talaga, yung mga indigenous peoples nila, talagang nadi-displace. No? Pero when you zoom out, global south naman ang taas. So, I have conversations also with other anti-colonial scholars. And while we have the same liberation sociologies or liberation aspirations, the way we understand the root causes of our problems are different, no? Kasi tayo, national colonial history, sila talaga very specific to an indigenous land, very land-based. Although land-based pa rin naman tayo. Although in our argument kasi sa atin naman, within the national, there are sub-colonies, no? Yung Imperial Manila, which again, I am very reflexive of as a person, no. Syempre as a scholar, alam ko as a Manileño, I have my own privileges, no. So I also have to cede my power eventually, no, when this becomes a thing, hopefully, no. And so this was my thought, no. So what was my conversation? So the argument is that in nursing, again, there is a universe of knowledge, meaning there is a common source of knowledge that is trickled down in global south, in the global chain of knowledge. And that's what I call the pyramidal epistemology. Yung nasa taas ay mga American, European scholars, and yung mga nagawa nilang mga theories in the 1950s, 1960s, 1970s, binababa nila sa amin. And Filipino nurses, Indian nurses, African nurses are really just, they just need to abide by those theories, look at the contextualization of the theories in their native countries, because this is universal naman. And that is what I'm trying to fight. That there is, that maybe that is also a colonial expression, a colonial manifestation. So if you really want a just discipline in nursing, we have to consider that it's not a universe of knowledge, but a pluriverse of knowledge, that we have our own epistemological tools in our specific cultures for us to be able to theorize about health. No, and so my argument is that there has to be a pluriverse of nursologies, not just an universal nursing knowledge that really in actuality is an American nursing that you just gave to us. So that's sort of the articles that I'm writing on, and I think it's getting traction naman. People are citing me, no? Naniniwala naman sila sa mga laban ko, I think, no? And specifically in the Philippines, I'm trying to start this idea of Narsolohiyang Pilipino, something similar to Psikolohiyang Pilipino, which I'm very much inspired of, but also I want to make it quite unique to our case in the Philippines, no, arguing that, so there are three rationals, no, rational justifications. One is, of course, very colonial pa rin ang health sa Philippines, and yung colonial, well, although of course there's a lot that we have to think about biomedical knowledge for decreasing mortality, decreasing morbidities in the Philippines, improving productivity, but also we can't say na we haven't, that some of these colonial practices in health that we are using from our colonial public health ideas are also very hurtful. Like, for example, the way we view sex, the binary of male and female, no, the idea of trans, which is not necessarily bad, but some people might not be able to categorize themselves as trans, because trans is also a Western invention, no. Next is the idea that there's a lot of epistemic health resources in the Philippines that had been sidelined but had been very useful. Hilot, herbal medicines, no, faith healing, and other things. And there are also health issues that may not have a biomedical cause or a biomedical explanation, but are actual health phenomenon in the Philippines, like sumpong or usog, right? They really don't have any biomedical explanations, but for those who are affected by it, it's real for them. So if we are not putting any academic attention on this, then there is a set of population and conditions that we're not addressing. Diba? So yun yung argument nito. This is not again to sideline biomedical. What I'm saying is, let's open the space for non-biomedical, non-global north, non-Euro-American knowledges to, pitch into that conversation. Not just a 3-hour lecture in curricula. No? Yun yung argument. And of course, ito talaga yung pinakamalaki ko na so we're arguing that the Philippines is the largest nurse-sending country in the Philippines. Ang argument dito is, kung tayo ay, by the way yung mga nurses sa ibang bansa, hindi lang tayo staff nurse lang. We eventually become nurse educators there. Filipinos become nurse administrators, chief nurses in the States. And they're able to transform health systems there. So I would argue na we are also Filipinizing healthcare in the world, because when we go abroad, we also carry our embodied cultures there. And there's no one talking about it. Again, when we're seeing health textbooks in the States, it's still as if we're still invisible, where in fact we are in every hospital in the States. So why is that not being put in the academic conversation? So this again, one of the rationales, no? So hindi ko na to anuhin, no? So I use the term dalumat, and thanks to our friends from the Philippine Studies na parang this could be a way for us to do. So the overall goal, which is the current project that I'm doing with the OSD now, is to really just deepen further, no, how can we make an actual scholarly field, no, whose research methods are Filipino, whose philosophical underpinnings are really Filipino, so that we can enrich this knowledge and we can really make it a formal academic exercise, not just a 3-hour appendix in the books that we're reading, no? So yun siya. So thank you. That is the last. I don't know how long this video is already, but as you may have noticed, critical public health is really my cup of tea, right? Looking at health as an institution, medicine as an institution. Hopefully, it's sad that I really wanted to cut this particular session into 2, but again, we lack time already. So I hope you bear with me. But I hope you're able to understand your social reality better now and the way health is being done in the Philippines through the sessions that we've had. And I hope you learned a lot. Thank you.